Hi everyone, my name is Melanie Grant and welcome to part 2 of this week's part 2 of E&M coding for our class 2030 with CNM Glass. By now you should have already watched our video on exams and the different types of elements for 95 and 97 guidelines. This video is to go over medical decision making and the 3 different components of medical decision making and how we determine the overall total MDM. I like using that abbreviation because saying medical decision making 5 times fast can be a little bit of a tongue twister. Okay, so first thing I want to say is take it one step at a time. It's very easy to get lost when you're looking at your MDM because there's so many different steps and each one has a couple of unique quirks, and then within those quirks you have to put them all together at the end to determine the overall MDM. So take it one step at a time. We first look at number of diagnoses, then data options, and the 3 levels of risk. And I always like to make a joke that they love to give us things in 3s because they've done just that. They've given us 3 key components for your E&M visit, 3 different parts of medical decision making, and 3 levels of risk. So we'll look at all of those in due time. For now, let's talk about the number of diagnoses. One of the little quirks that I like to give is to think of diagnoses as a number that is quantitative. I'm missing a little in there. Quantitative, meaning when you say quantity over quality. Quantity is the number, how many. When I say quantity, I remember when we talk about labs and how we talked about the quantitative lab tests that tell me how much of something was there versus the qualitative lab tests that told me something was there. And so for the same concept, I like to apply these to my medical decision making. It helps to branch off similar concepts. So we add each of these together. If you look at your medical decision making part of the scorecard from the Novitas Solutions scorecards, you'll see that they've broken it down like a math equation, and they call it A plus B times C equals D. I look at that and my head hurts. I'm like, A plus what? But think about it easily enough. How many of this category applies times or plus the maximum number, so A plus B equals, I'm sorry, they didn't say A plus B, they say AB times C equals D. So they're not wanting you to apply A. Sorry about that. They want you to say how many of A apply and if B has any restrictions. Okay, so you kind of have to look at that as a just really overall how many of this number, unless B says not that many. So if I have category 1, self-limited or minor problems. Self-limited or minor problems, let's talk about that for a moment. This is a problem that does not need treatment, is either resolved or is not really a problem at all, but more of a concern that maybe the patient came in to look at. There's no test done in order for us to determine what's wrong with them. And the provider basically looked at them and said, yeah, that applies. And so nothing else was done after that. Otherwise, it would not be a self-limited or minor problem. So keep that in mind. Something such as a mosquito bite. They do mention stable, improved, or worsening, meaning that it can be any kind of self-limited problem. Follow-up to a urinary exam or a urinary tract infection, for example, would be a self-limited problem if it's already resolved. So there's a good example for that. So you're going to say your self-limited problems up to 2. So if I have 5, but I have a restriction of 2, then I'm only going to say 2. And then times the number of points that that is worth. So C is the points that it's worth, which is a set number, so that's 1. So I can only have 2 points total for that area. Establish problems to examiner, stable, or improved. This is a key word here, to examiner, meaning the provider of service has not seen them or has seen them for this problem. It makes it established. Okay? And then for it to be stable or improved, it's considered also not worsening. Okay, so it may be not worsening, and maybe they didn't use the word stable or improved, but they didn't feel the need to do anything different for the patient for their treatment. So an established problem to the examiner, something they've seen them for, that is stable or improved, can be any number. So I can have 5 different problems here, and because there's no restrictions, I'm going to bring 5 times 1, and I can have up to 5 points. Established problems to the examiner that are worsening are worth 2 points. So if I have 5 of those here, there's no restrictions, I can have up to 10 points. And then you have new problems to examiner. Now keep in mind that if it's new to the examiner, this can be old to the patient, such as a patient with diabetes that's being seen for the first time with a new provider to establish care because they've moved or changed offices or insurance, and they just really need to get their medications refilled and continue to have a provider of care for that ongoing, stable condition. In that case, it would still be new to the examiner, the provider, because they had not seen that patient for that problem before. So I would say new problem, no additional workup planned, versus new problem, additional workup planned. So you have to identify whether or not workup is planned. What is workup? Well, that's any kind of diagnostic or other data that's needing to be ordered or reviewed that would be found in the complexity of data reviewed or diagnostic procedures ordered. So you want to look at those categories to see what they consider workup. If it's a new problem to the examiner with no additional workup planned, notice that they have a maximum of 1. So I may have 5 new problems with no workup planned, but with a maximum of 1 and 3 points, 1 times 3 is only equal to 3. So the fact that these are new problems, but we didn't need anything else, just means like, okay, you're new. We're going to see you for all the problems that you have, and it looks like we don't need to do anything else. Everything's been going great. So this is only worth 3 points in terms of your diagnoses. And the new problems that do need workup do not have a restriction and are considered 4 points each. So if I had 5 times 4, goodness, I would have 20 points. Now here's the thing though, as in terms of your level of medical decision making, and we'll kind of throw a little level over here while we're talking, you have at the very bottom of your medical decision scorecard, A, B, and C, and you have straightforward, low complexity, moderate, and high. Okay? And for each of those areas, you have equal to or less than 1, 2, 3, and 4 for column A, which means that no matter where you're on here, I'm going to have a high level of diagnoses if I have any of these categories, whether it's 5 or 20. So I can really stop if I know I have at least 1 problem that's new with workup. I don't have to look at all the diagnoses that are on there to know that I'm going to hit the highest number of medical decision making for that part. So keep that in mind when you're counting up diagnoses. You only need to get to 4 or more points before you're at the highest. So if you have a lot of diagnoses, you don't have to go through the steps of determining every single diagnosis and the type of diagnosis it is. So it's just kind of one step at a time, and what can you eliminate that's extra work? But also, because we're all new and we're all learning, I want to make sure that you're not eliminating things without understanding them. So make sure that you take a time to go through that and say, what kind of diagnosis is this? Is this new to the examiner? If it's new, is there additional workup? If it's established, is it stable or just not worsening? Or did it need some sort of change to the plan? Your next one is your data options. Okay, so let's talk about data. Data options are found at the top of your medical decision-making scorecard, and they don't have any math to do with them. They only have 1 or 2 points per category, and you'll also notice that this is going to be the same level of 1, 2, 3, or 4. So equal to or less than 1, and by the way, this is for the equal to or more than. I'm sorry, that should be under C. And yes, we go A, then C, then B. So this has the same amount of points in this category for C, which is your data here. However, it's harder to get to that 4 or more. So you'll notice that it's very common to get to 4 or more in A with the amount of diagnoses and the types, but in C, it's very common to be at the very bottom. So let's look at that. For data options, it's qualitative, meaning quality, meaning it's either there or it's not. So we only add the number that's assigned for each category, and we only add it once. So we have here review and or ordering of lab tests. So I just say anything about labs, yes or no. If so, that one's worth 1 point. The next one is the same thing. Review and or order of test in the radiology section. So I say any kind of x-rays, any kind. Doesn't have to be x-ray. It could be other types of MRIs or CT exams. Yes or no? And that's only worth 1 point. The third one, and you'll notice the reason that we looked at the medical section of CPT earlier on, the third one is anything of the tests in the medicine section. Test, mind you, like your cardiology tests, such as an EKG. Okay, so I'll say med test, yes or no, and that's equal to 1. Okay? After that, you have a couple of them that are a little different, such as discussing a test results with the performing physician. So if we discuss a test with the performing physician, that's such as calling up the radiologist and saying, hey, I see that you said there was no abnormalities in this x-ray, but when I'm looking at their lungs, it looks like there's a little bit of a discoloration in this part. Can you look at this again with me? Or perhaps the provider is going to someone who did the EKG and said, hey, I noticed this weird fluctuation. Did they move here? Did something happen? Why is this odd? And this will be more common that they're discussing tests when they're in the inpatient setting rather than the outpatient. Again, we're going to say yes or no, and that one's worth 1. The next one's kind of a cool one because it applies a lot of times. The decision to obtain old records and or to obtain history from someone other than the patient. Now keep in mind this is a decision for more info. If you think of it like that, decision for more info, yes or no? 1 point. So if they say, I need the patient to have their old records from such and such medical office sent over, and that's all they said, that's a point. Or if they say, I need to call the patient's son because she seems a little disorientated and we need to determine if she has some sort of dementia that's starting to happen, that's a point. If they say, I'm going to call the patient's adult child or parent and ask them about something, that's a point. So anything that they say, I need to follow up and get this information, I don't have it today, I need it, that's a point. Now, likewise, the difference between that and the next one is review and summary. Info or history. Okay, so review and summarization of old records and or review and summarization and obtaining history from someone other than the patient and or discussion of the case with another healthcare provider. So in order for you to hit that, the and or means that there's 3 different parts of this category. You can review and summarize old records. So you have the records, you are indicating what records they are and what the information about them is. So it doesn't count if they just say, I looked at the old records. And how is that relevant to our patient now? Remember, we're determining the medical decision making that the provider put in here. And them just saying they read something doesn't mean that they read it for the purpose of the patient. They may have glanced at it and said, I don't need to look at this. And that's fine. But if they don't summarize it, they don't get credit for it. So this part, they're getting paid for the time that they're taking to tell us why is that relevant, so that the next provider doesn't also have to go and look at that old record and say, what was in the old history? Obtaining history from someone other than the patient. I can't tell you how many times I have a 6-month-old baby that told us all of his or her symptoms and coughing and how long they had been miserable. That being said, the doctor does have to document who that person is, even if it's fairly obvious. Even if they say patient is here with their mom and is experiencing, we don't know that mom said that or that the provider observed that. And while it's most likely that mom said that, we cannot ever assume when we're determining a medical claim. So because of that, we have to say, Dr. So-and-so, make sure that you're documenting who's giving you this information. I see that you've said mom was here, but we need to make sure to identify who's providing the information. That's also important just in case they were here with mom, but dad happened to be in the room, or maybe the doctor had talked to the dad prior to or after, and they need to make sure that they have that information in there, especially in cases where parents may no longer be together. The third part of this one here is discussion of a case with another healthcare provider. This is where they're in the same office and they say, look, I need your opinion, I need your help. And they document it in their note. This is more than just discussion of test results. So if the specific information is the test results with whoever performed it, that went up here. But if they're discussing and summarizing the information about their health care and trying to make a decision, then we're going to count it in this category. And this category, for all 3 of its areas, is counted as 2 points, regardless of how many times any of those 3 areas apply. So they may come in, the provider may have looked at old records, they got 2 points. They may have also gotten history from mom because it's a 6-month-old baby. They already have the 2 points, we don't add. They may have also discussed it with a colleague because it was a complicated case. They already have those 2 points, we don't add. So that's how that category works. Your last one is an independent visualization. Tracing or specimen itself, not simply review of a report. What this is talking about is if they looked at the lab, x-ray, or the medical test themselves independently and did not bill for doing that, then they can say, I independently reviewed these results and this is what I saw. They're not looking at just the report, but they're also not billing for the report and summary itself. If a doctor, the reason why that's important is a lot of doctors bill in office for some of the med tests like the EKGs, and if they're independently looking at that tracing as part of the EKG itself to be billed, they can't double dip that. They can't say, oh, well, I looked at the tracing, so I'm going to bill for that, and I'm also going to give myself more credit in the medical decision. It doesn't work that way because they have to determine where that credit's going to go. But in a lot of cases, another provider may have done that service, such as the labs or x-rays, and billed for reviewing it and providing a report, but maybe the doctor that ordered it wants to look at it themselves. So they put it either under a microscope if they have the specimen, or they pull up the film from the x-ray or whatever imaging, or they looked at the tracing to say, how do I want to interpret this? Do I agree with the original provider? Yes or no? Always yes or no. If so, and if it's clearly documented and not separately billed, that's 2 points. At the end of this category, you're going to add them all up. Now, a lot of times, unless you have a sick patient, the only thing that you might have is labs, and potentially you could have reviewing and summarization of old information or history from someone other than the patient. If it's documented and clearly stated, you add each of the points for each category that applied, as they indicate, so that's a total of 3, and determine at the bottom of your medical decision making what level that's at. Easy as pie, right? Or maybe clear as mud. So now we look at the risk. When we talk about risk, the first thing I want you to know is that risk is what is the level of risk to the patient for us to treat them, okay? We're not talking about level of risk that the patient necessarily has by just being alive or by having a specific type of diagnosis. We're talking about the level of risk they're presenting with today. So there's 3 different categories of this, and risk works based off of the highest level. So it can be in any of those 3 categories of risk that you have the highest level at. Okay, keep that in mind. Your level of risk for presenting problems. Doesn't this sound a lot like diagnoses? It is actually. In fact, if you look at it, the first example is one self-limited or minor problem. Hey, that was very similar to number of diagnoses. In fact, if you've already looked at number of diagnoses, then some of this will help you to identify the types of problems. They give an example of a code, insect bite, or tinea corpus. But remember, a self-limited problem is only identified as such if there's no treatment and no diagnostic services being done. So if they do any kind of labs to determine, hey, is that cold strep? Or if they're doing any kind of prescriptions to say, hey, you clearly had an allergic reaction to some insect bites, let's give you an antihistamine. Even if it's over-the-counter medications they're telling the patient to take, then that is not a self-limited problem. It is instead going to be an acute, uncomplicated problem or injury, which is part of your next level. So you have here minimum, low, moderate, and high. Okay? And you'll notice that these kind of relate over here to straightforward, which is like saying minimal, low, moderate, and high. Okay? So presenting problems, you're going to determine what type of problem are presenting. If the patient, for example, is presenting without any problems whatsoever, and so maybe they came in for a problem they had a couple weeks ago, then that would be considered self-limited. It's no longer a problem. One way I like to talk about presenting problems. What kind of smiley face does the patient have? We all know this from going to the office and talking about levels of pain. So what kind of problem are they presenting with? Is it fine? Is it, well, I'm not really happy with it? Is it, oh no, it's not good. It's really not good, I'm unhappy, it's affecting me. Or is it, oh my God, I'm dying, please help me now. And I don't mean that in any sarcastic way at all. I've been at all levels of these myself. So identify the type of presenting problem. 2 or more self-limited problems, even though they're both happy, will fall under a low category. Just as one stable chronic problem that's well controlled, and if it's controlled, it's probably a happy thing, and acute uncomplicated illnesses and injuries. However, under the moderate section, 1 or more chronic illnesses with a mild exacerbation is going to actually be moderate. And mild exacerbation means any kind of complication. So if they have, say, for example, hypertension with elevated blood pressure or diabetes uncontrolled, then that's going to be considered a mild exacerbation unless the uncontrolled is severe. And it's all about how the doctor documents it at that point, because mild exacerbation means that, yes, it's exacerbated. However, I can have a doctor tell me that they have acute asthmatic exacerbation versus acute asthmatic exacerbation with difficulty breathing. Okay, so they really have to be clear, because your high is 1 or more chronic illnesses with severe exacerbation, progression, or side effects of treatment. And so you may think something sounds severe, but compare that to the options of acute or chronic illnesses that, or injuries that may pose a threat to life or bodily function. Now they're talking about currently posing, not the fact that they have it could pose. So if I have a patient with cancer who seems controlled, that's not a high risk. But if I have a patient with asthma and they cannot breathe and they're sitting here gasping for air, that is high risk. That could potentially mean life or death or loss of a body function. An arm, for example, with severe infection that they may need to amputate would be considered a high risk. Also in the high category is any abrupt change in neurological status, such as a seizure, TIA, weakness or sensory loss. So if they mention that they seem disorientated and unable, and it's a severe acute change or abrupt, then you can consider it high. Diagnostic procedures are your next one. And it's pretty much a common one of what was ordered and did it apply. So under diagnostic procedures, you'll notice that all of your diagnostic procedures that were under data, for example, such as lab test, if they require venipuncture, so not a urinalysis, it is listed those separately. Chest x-rays, also any other x-rays. Why they just say chest, who knows. Ultrasounds, urinalysis, KOH prep, these are all examples, not everything. So if it's at the same level, it's considered that level of risk. Versus psychological tests not under stress, non-cardiovascular imaging studies with contrast, superficial needle biopsies, and clinical lab tests requiring an arterial punch, as well as skin biopsies. Then you have your psychological test under stress, diagnostic endoscopies with no identified risk factors, deep needle or incisional biopsy, and cardiovascular image studies with contrast and no identified risk factors, and obtaining fluid from a body cavity. So I want to stop there. Most of them are pretty basic. The difference that I want to point out is identified risk factors. So you may remember from anesthesia that when we talked about the P status, we talked about the different things that caused risk. Okay, so when a patient is going in for a procedure, there is a level of risk that is identified with the patient that's not identified from their causes. It's just risk in general, such as this procedure could cause bleeding, infection. Possible infections could lead to potential loss of use or death, or however type of detailed the surgery is. Those are risk factors associated with the surgery, not the patient. An identified risk factor for the patient would be something that's systematic, such as hypertensive patient. And so if they're ordering a cardiovascular image study with contrast and identified risk factors, such as having problems with their hypertension, then that's going to be considered high, because the risk factor is the hypertension, not the risk of the procedure, but the risk of the patient. Then our last area for levels of risk are your management options selected. Most of these are pretty basic until you get to the high. You have things like rest gargles, bandages, dressings. Over-the-counter drugs is one of your big ones. Minor surgeries with no identified risk factors. So those are like in-office procedures. Physical therapy, occupational therapy, IV fluids without additives, so just the saline. Versus your moderate, this is where you get most of your risk, by the way. It's very common for us to have a moderate level of risk based off of, say, prescription drug management, any type. So, prescription ibuprofen falls under prescription drug management. Controlled substances and opiates falls under prescription drug management. Keep that in mind when you're looking at these. IV fluids with additives, minor surgeries with identified risk, so again, identified risk, not of the surgery, but to the patient. Close treatment of fractures or dislocations without manipulation. And then you're high. And keep in mind, if you get to this section of risk and you say, are any of these high, it needs to be clearly documented by the provider. An elective major surgery, an emergency major surgery, perinatal controlled substance, or parenteral controlled substances. I'm giving them to babies now. Parenteral controlled substance, these are substances that are given to the patient through the IV. So it's not just controlled substances, it does have to be very specifically given and monitored. Drug therapy requiring intensive monitoring for toxicity. This is common with Suboxone clinics where patients are coming in to get off of more severe drugs, and so they have to constantly be monitored for their levels, and also Coumadin. So if it's stating in there, we need to do monitoring for this drug for toxicity, then that's going to be what it is. And then last but not least, the decision not to resuscitate or to de-escalate care due to a poor prognosis. This is saying that because the patient is severely ill, they've decided today to put a DNR on file or to stop the current treatment. This is not saying that, hey, during our visit today, we talked about all the risk of being on resuscitation, and they decided they didn't want that. So keep in mind, it's due to a poor prognosis. From there, look at all three of the different areas. So you have management, and you have pretty basic drugs, OTC, identified risk factors and prescription drugs, and then very specific information for your high. At that point, look at all the different options. If I have a patient presenting with 2 chronic but stable conditions, they're going to fall under low. Let's say I ordered some lab tests and a prescription was refilled. I'm going to look at this and I'm going to say, what's the highest level of risk? And based off of that, that highest level of risk is going to come over here to my level of medical decision making overall. And I have minimal, low, moderate, and high. Okay, so no matter, you don't have to worry about how many of each category you have. It's just the highest level of risk determined from all 3 categories and what level that is, and then come over here at the bottom of your medical decision making, and we're going to do the overall, the final result for complexity. Whew. Take a breath now and give yourself a pat on the back. The last part of medical decision making selection. And remember, 1 step at a time. I erased that, but it still needs to be remembered. We take this 1 step at a time. So far, we've looked at our number of diagnoses and treatment options, which were a quantitative number, meaning we added them together based off of the categories and how many points each was worth. We had our data options, which are a qualitative number, meaning that each category had a specific number, and if it applied, we added that specific number. And then we had a level of risk, meaning that we looked at all 3 levels of risk, determined the highest out of the 3, and determined our level. From here, we're going to consider each one of these levels as if it includes all of the previous ones. And so you'll notice that when I'm writing on your PowerPoints that I select the one that applies, and I use a little line to denote that everything below it is also included in the higher number. Now from here, for our overall medical decision making, or the final result of complexity, I have to determine 2 of 3 of these circles to figure out which one applies. In other words, your lowest one drops off. It's not important. So if I have 2 here that are at the same level, it doesn't matter which one I don't count, but I'm going to say the highest possible first. Do I have 2 or more in my high complexity? No, I only have 1, so it's not high. Do I have 2 or more, and this counts as 3, in the moderate? Yes. And so I'm going to choose moderate level of risk, or of MDM, sorry. So a moderate medical decision making is determined when 2 or more of the 3 categories of MDM are at the same level, and that's the highest we can go. If, for example, we had had a 2 on this second category instead of a 3, what level would I have? Well, let's put it up here so we can kind of see a visual. Okay, if I had a 2 instead of a 3, I would still have 2 in the moderate. So the high would still not apply, but because I had 1 in a high category and 1 in a moderate, I had 1, 2, so I would still be a moderate medical decision making. Even if I had none here, it doesn't matter. And in fact, it doesn't matter which of those 3 applies, so long as 2 or more do. So you could have a patient with very low risk that has a lot of testing and a lot of diagnostic and treatment options done, and they can still fall under a high category. Keep in mind, the last thing you want to consider is that there is a guideline that medical necessity must be supported. Medical necessity is oftentimes looked at as the level of risk for the patient or why we did something, why it was important to do it. And so a doctor must clearly document all of their medical decision making as to why they looked at this and why it was important. So we want to always make sure medical necessity is supported in some way, shape, or form. It's a term you'll hear often in the medical world. That's it for medical decision making. Next week, we're going to look at all three of these components and put them together in a couple of different attempts to see the full overview of the visit. This week, you should be going through the PowerPoints and some of the other review materials and seeing that already. So if you have questions, feel free to send them to me. Until next time, have a great week.